veterans and their families, which is taking place on July 30, 2024. Next slide, please. So I'd like to introduce you to your moderator for this webinar, Ms. Stacy Owens. Ms. Owens serves as SAMHSA's Military and Veteran Affairs Liaison. And in this role, she facilitates collaborative efforts to enhance mental health for service members, veterans, and their families. With 20 years of diverse healthcare experience, she previously served as a public health advisor in SAMHSA Center for Substance Abuse Treatment. Prior to SAMHSA, Ms. Owens dedicated 13 years as a clinical social worker for SMVF at VA and DoD. Alongside, she worked as a PRN mental health clinician conducting suicide risk assessments for incarcerated individuals. Ms. Owens hails from a proud military family. Her father is an Army retiree, both grandfathers were combat veterans, and her niece is a cadet at the University State Military Academy at West Point. So with that, I would like to say hello to Stacy, and the floor is yours. Thank you.
Thanks so much, Chantel, and hello, everyone. Thank you so much for joining us for this webinar. Next slide, please. First of all, I'd like to say that the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of SAMHSA or HHS. Next slide, please. This webinar is being sponsored by SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center, which partners with states, territories, and communities to increase behavioral health support for the SMVF community. SAMHSA is the agency within the Department of Health and Human Services that leads efforts to ensure that mental health and substance use treatment needs of all Americans are understood, including the needs of the SMVF community. Next slide, please. The SMVF TA Center provides technical assistance support in a number of ways through monitoring evolving trends, providing technical assistance through training tools and consultation, as well as identifying and recognizing the importance of best and promising practices, providing access to subject matter experts in the field, and also supporting state and territory interagency teams to plan their efforts. You can access the SMVF TA Center through that QR code there. Next slide, please. The activities of the Technical Assistance Center include academies for jurisdictional teams, crisis intercept mapping for SMVF suicide prevention, webinars like this one, as well as learning communities, technical assistance calls, consultation with subject matter experts, and resource dissemination. Next slide, please. Our learning objectives for you today include exploring how CCBHCs help to bridge the gap in accessing behavioral health care in communities and providing comprehensive support to SMVF and other populations. You'll also have the opportunity to learn how the VA's Compact Act enhances access for veterans who are in need of emergency suicide care within community-based settings. And lastly, you'll have the opportunity to understand how within your community settings, you can synergize efforts with veteran serving partners to strengthen service delivery for SMVF. Next slide, please. Our presenters today include 4 experts in their field. We're actually going to start with a couple of my SAMHSA colleagues, Dr. Leela Desala and Dr. Abdallah Ibrahim from SAMHSA's Center for Mental Health Services. Next slide. And then we'll also have Michelle Suri, who serves at the Department of Veterans Affairs as an integrated care management nurse within their Office of Integrated Veteran Care. And we will end strong with Sarah String, who provides oversight for the Mobile Crisis Outreach Team and the Resiliency Team at the Harris Center for Mental Health and IDD in Harris County, Texas. Next slide, please. So I would like to start by introducing my SAMHSA colleagues, Dr. Abraham and Dr. DeSala. Dr. Abraham serves as the coordinator of the branch that provides oversight for CCBHCs. And Dr. Leela DeSala serves as a public health advisor within that branch, and she is a Navy veteran herself. You can read more about their bios within our webinar announcement, but we wanted to go ahead and transition the floor to them to hear more about CCBHCs. Dr. DeSala, I believe you're first.
Thank you, Stacy. I would be going over the CCBHC first and then turn it over to my colleague, Dr. DeSala, to provide some sort of outcomes regarding CCBHC outreach and access to military and veterans families as well as the general population. So this is just an overview of what we'll be going over today with regards to CCBHCs. We would be looking at what in general is the CCBHCs, who are our federal partners, the impact of CCBHCs, and how the CCBHC has grown over the years. Next slide, please. So what is a CCBHC? The CCBHC, or the Certified Community Behavioral Health Clinics, they usually brings together a comprehensive range of services that incorporates evidence-based practices and other supports. And those supports and services are usually based on community needs assessments that precede services. CCBHCs provide improved access to mental health and substance abuse services, including increased capacity to be able to respond to those mental health and substance abuse crises. CCBHC serves individuals across the lifespan and for those with mental health and or substance abuse use disorders. CCBHCs are required to meet certain certification criteria, which I will talk in detail later. Next slide, please. There are three federal agencies that partner to implement the CCBHC initiatives, and these include SAMHSA, which is our agency, Substance Abuse and Mental Health Services Administration, CMS, which is the Centers for Medicare and Medicaid Services, and the Office of the Assistant Secretary for Planning and Evaluation. So SAMHSA's role or responsibility for CCBHC include administering the one-year CCBHC planning grants for states that are intending to develop proposals to participate in the time-limited CCBHC demonstration program. SAMHSA also oversee the implementation of the CCBHC criteria, as well as the CCBHC expansion grants, which are usually grants given to CCBHC individual clinics all across the United States. And CMS is responsible for the development and oversight of the CCBHC prospective payment system requirements, and the development and oversight of the CCBHC cost reports, which support the PPS, or the prospective payment system rate developments. That is based on the Medicaid, federal Medicaid assistance percentage claim expenditure under the CCBHC demonstration program. And finally, ASPE, or the Assistant Secretary for Planning and Evaluation Office, is responsible for conducting an independent national evaluation of the CCBHC demonstration. Evaluation activities are used to generate annual CCBHC reports to Congress, and also evaluation report as required by the statute. Next slide, please. As I mentioned earlier on, CCBHCs are based on certain criteria or certification criteria. And at the heart of the CCBHC is 6 main building blocks, or the main pillars of CCBHCs. And these are staffing or workforce, availability and accessibility of services, care coordination, the scope of services, quality and reporting, And finally, the organizational authority and governance of the CCBHCs. So in addition to these 6 pillars, or the foundation on which a CCBHC stands, there are also 9 CCBHC core services that any organization or agency that is designated as a CCBHC is required to provide, either directly or through their formal agreement with a DCO, and the DCO are direct care organizations. And I'll just go over briefly all these 9 core services that a CCBHC is required to provide. And these services include outpatient mental health services, as well as substance use services, person and family-centered planning, community-based mental health care for veterans, which I would go in detail later, peer and family support counselor services, targeted case management, outpatient primary care screening and monitoring, psychiatric rehabilitation services, screening and diagnosis and risk assessment, and finally, crisis services. So these services, as you can see, they are all linked to the core pillars of the CCBHC. That is the earlier one that I mentioned, with the staffing and access, care coordination, scope, quality, and organizational authority. All these core services are linked to those core, or the 6 pillars of the CCBHC. Next slide, please. So as I mentioned earlier, CCBHC has certain requirements. And with regards to this particular presentation to this population, the care coordination agreements for the Veterans Administration. CCBHCs are designed to provide improved access and high quality integrated comprehensive community behavioral health care. And among the criteria to meet the certification specifically involve service to veterans. So CCBHCs must have a care coordination agreement in place with any of the nearest Department of Veterans Affairs Medical Center, independent clinics, a drop-in center, or other health facility of the VA department. The written agreements must ensure seamless transitions for patients across the full spectrum of the health services, including acute care, chronic, and behavioral health needs of veterans or service-connected individuals. And secondly, CCBHCs are responsible for intensive community-based behavioral health care for certain members of the U.S. Armed Forces and veterans, particularly those armed forces members that are located 50 miles or more from the nearest military treatment facility. And for veterans that are living 40 miles or more, that is a driving distance from a VA facility, or as otherwise required by federal law. Next slide, please. So the components of the VA agreement that I just discussed include the following. So for CCBHCs to establish those care coordination agreements with the VA, the CCBHCs are required to ask and document, asking all individuals that are seeking services whether they have served or have ever served in the U.S. military. And for those affirming current or former service in the military, the CCBHCs either direct them, are supposed to either direct them to care to any of the facilities that I mentioned earlier, or actually provide the care themselves to the individual. So what I'm just going through right now is actually components of the language that is required to be part of the agreement. And then another component that is supposed to be included in the agreement is the fact that CCBHC must offer assistance with the enrollment in the Veterans Health Administration for the delivery of health and behavioral health services to persons that are affirming former military service. And also CCBHCs are required to include in the agreement the provision or coordination between the care of substance abuse, use disorders, and mental health conditions for veterans, as well as active duty military personnel who experience both, to the extent that those services are appropriately provided by the CCBHC. Next slide, please. The other components that are supposed to be included include in the agreement include the provision for the integration and coordination of care for behavioral health and other components of health, or that this is in this case non-behavioral health care for all veterans and active duty military personnel who experience both behavioral health and non-behavioral health, to the extent that those services are appropriately provided. And then CCBHC must include in the agreement that a principal behavioral health provider would be assigned to every veteran that is seen, unless that veteran is actually already connected to the Veterans Health Administration. And then CCBHCs must also include in the agreements that care and services for veterans that are recovery-oriented also adhere to the guiding principles of recovery, Veteran Health Administration recovery, as well as the Uniform Mental Health Services Handbook of the VA. And also in the agreement, there should be the fact that any trained staff or CCBHC staff are supposed to be trained on cultural competency and but specifically related to the veterans population, military and veterans culture, and also develop a behavioral health treatment plan for all veterans that are receiving behavioral health services. Next slide, please. I'm going to turn it over to my colleague, Dr. DeSola, to discuss some outcomes with regards to access to services for CCBHC of the veterans or service-connected military family. And over to you, Dr. DeSola.
Thank you, Dr. Ibrahim. So with this slide, it shows both the active duty and veterans that served in the CCBHC grants for FY 2022, 2023, and 2024. And with that, 193,239 individuals were seen. And with that initial assessment, ever served in the military, adult clients, and if yes, if they served in the military, are they on active duty? So you can see, this is just a snippet to give you an idea of the certified community behavioral health centers in both the active duty and veterans data. Next slide, please. This slide really shows a snippet concerning the CCBHC Medicaid demonstration findings concerning improved access to care. And this is all from the findings from the National Evaluation of the Certified Community Behavioral Health Clinic demonstration. And there's links if you want a deeper dive. But what is this slide about? It's about the improved access to care. And what are the elements involved with that? So in the middle, you will see responsive to community needs. And with that, there's expanded hours that are involved. There's open access to scheduling that's involved. Services provided outside of that clinic is involved. The element and use of telehealth is involved. And also the outreach to underserved populations that's involved in that element. So look at the very bottom where it says homeless shelters. That's at 11%. 20% is community service agencies and nonprofit organizations. 30% is hospitals and EDs. 33% is courts and police officers and other justice-related facilities. 47% is schools. And then at 78%, there's, involved with consumers in their homes. So if you want a deeper dive with that, the link is provided. And we'll share that if needed. Next slide, please. So this slide really looks at a deeper dive into the SPARS data findings, between 2021 and 2023. And with that, it's from baseline to 6 months reassessment. And with that, its health is at 14.5% increase in overall health, 25.8% increase in functioning in everyday life from baseline to the most recent interview, 30.6% decrease in the number of consumers reporting a serious psychological distress. There was 13.2% decrease in use of illegal substances from 2021 to 2023, a 20.9% decrease in binge drinking, 32.7% fewer reported experiencing homelessness within the past 30 days, 73.1% fewer reported being hospitalized for mental health care within the past 30 days, 63.1% with fewer reported in inpatient substance use disorder treatment within the past 30 days, 68.5% fewer reported having utilized an emergency room for behavioral health issues within the past 30 days. And then social connectedness showed 15.1% of adults with an increase in social connectedness. Next slide, please. This is a map of CCBHCs across the United States as of March of 2023. And it's a great slide. I think that it's a good snapshot, but it includes, there are more than 500 certified community behavioral health clinics across 46 states. And that's including the District of Columbia and Puerto Rico. And CCBHCs may be part of a section of 223 Medicaid demonstration, independent state programs, or participating in SAMHSA's expansion grants. And these 15 states were selected to participate in the planning grants to prepare to join the Section 223 Medicaid demonstration. And those states are Alabama, Delaware, Georgia, Iowa, Kansas, Maine, Mississippi, Montana, North Carolina, New Hampshire, New Mexico, Ohio, Rhode Island, Vermont, and West Virginia. And then after a year-long planning grant period, these states were selected to join the Medicaid demonstration from July 1st of 2024, which is Alabama, Illinois, Indiana, Iowa, Kansas, Maine, New Hampshire, New Mexico, Rhode Island, and Vermont. And if you take a look at the states here that's color-coded in yellow, that's the federal CCBHC Medicaid demonstration and SAMHSA expansion grants. And the blue is state contains at least one local SAMHSA expansion grantee. And then that check mark over those states, CMS is an approved payment method for CCBHCs via a SPA or a 1115 waiver that's separate from the demonstration. And with that, next slide, please. This is another slide that's showing the certified community behavioral health clinics and the state CCBHC demos. So the existence demonstration states is Minnesota, Oregon, Oklahoma, Missouri, Michigan, Kentucky, New Jersey, and New York. And the new demonstration states as of July 1st of 2024 is Alabama, Illinois, Indiana, Iowa, Kansas, Maine, New Hampshire, New Mexico, Rhode Island, and Vermont. And then the new state CCBHC planning grants in 2025. These two elements, the first one is the first year grant awards up to 15 states to build capacity and apply for the CCBHC demonstration. And then by July 1st of 2026, up to 10 new states will be accepted into the CCBHC demonstration. And then on the right of that is just a snippet of the map of the clinic and state CCBHC activities that was previously talked about. Now here at the bottom, this is the CCBHC expansion grant program. We just recently had 5 regional meetings for the CCBHC, PDI, and CCBHC IA grant recipients. And in the blue, that regional meeting was in Washington, D.C. There was 98 CCBHCs that was in participation in February. Seattle in red, that was the hub for 72 CCBHCs to participate in that regional meeting in March. In New Orleans, there were 70 CCBHCs that participated in May. And in Chicago, there were 78 that participated in June. And then in Boston, the Northeast, there was 109 CCBHCs that participated in that 5 regional, the mid-regional meetings. Next slide, please. This slide shows the development timeline and, of course, the next steps. So in 2014, there was an authorization through PAMA in 2014. And then in 2015, there was a release of a certification criteria and a prospective payment guidance within 24 state planning grants that was awarded. In 2017, there were 8 states that started the section of the 223 CCBHC demonstration programs. And then in 2018, there was 52 CCBHC expansion grants that was awarded. They was awarded $100 million in appropriations. And every year since then, it's up to $385 million a year. And there are more than 450 active grantees nationally that's involved. In 2020 to 2021, 2 additional states were added to the 223 section with the CCBHC demonstration, which was Kentucky and Missouri, which was authorized by the Coronavirus Aid and Relief and the Economic Security Act. And then in 2022, there was a bipartisan Safer Communities Act that was authorized 10 states to enter the demonstration for every 2 years. In 2023, there was 15 grants that was awarded, and there was an updated certification criteria that was released. And then there was guidance released for existing demonstration states to add the CCBHCs. In 2024, there was up to 10 additional states that was able to join the demonstration by this month, July 1st of this year. And that was Alabama, Iowa, Illinois, Indiana, Kansas, Maine, New Hampshire, New Mexico, Rhode Island, and Vermont. And in 2025, for that future, timeline, there's going to be up to 15 additional planning grants to be awarded. And in 2026, up to 10 additional demonstration states added. And then 2027 plus, hopefully to additional demonstration states will be added every 2 years to that. Next slide, please. And this is the end of the presentation on our end, but if you have any questions or input, you can always, send it to the ccbhc@samhsa.hhs.gov. And then, of course, this www.samhsa.gov. Thank you.
Thank you so much, Dr. Ibrahim and Dr. DeSala, for covering that portion of the presentation. And thanks so much for your role in the funding allocation for CCBHCs and helping them grow. Looking at your slides, it just reminded me that this is the 10-year anniversary of the legislation that started CCBHCs, and to see that they've grown to over 500 across the nation is just really amazing. And again, thanks for providing that overview and a little bit of information about the statutory authority and what CCBHCs are tasked to do. It's definitely a big job, but definitely impactful throughout the nation. So we can go back to the next slide. And we are going to welcome to the virtual stage Ms. Michelle Sori, who, as I mentioned, serves as the integrated care management nurse with VA's Integrated Veterans Care Program. She has been with VA, I believe, for 21 years, which is amazing. And she has a big job as well, overseeing the authorizations with the Compact Act program. And Michelle, I recently read that the Compact Act served 50,000 veterans in its first year. So we're looking forward to hearing more about the program. Over to you.
Hi, good day, and thank you for having me. Always happy to speak with our partners about our services within VA and in particular Compact Act. Go to the next slide, please. So for those who aren't familiar, the Veterans Comprehensive Access to Care and Treatment Act, or otherwise known as Compact Act of 2020, expanded VA's authority to provide and pay for or reimburse eligible individuals for care and treatment related to emergent suicidal crisis. The Compact Act itself was passed into law on December 5th of 2020. And the goal of this law is to make certain improvements related to the transition of individuals service from VA, the suicide prevention care for veterans, and then care and services for women veterans and other purposes in general. The Section 201 in particular of the Compact Act is related to emergent suicide crisis care. The VA did publish an interim final rule on January 17th of 2023, and that instituted the benefit under Section 201. On the right-hand side of this slide is just one of our public-facing flyers that we use for the advertisement and of the Compact Act and eligible individuals and how the program works and where to call if they have questions. Next slide, please. So what is emergent suicide crisis care really? So this is an individual that's determined to be at imminent risk for self-harm by a trained crisis responder or a healthcare provider. And that imminent risk can be determined if the individual states their intent of self-harm, there's knowledge of an individual's past or present behavior indicating risk of self-harm, and then also including past suicide attempts. This picture here on the slide really is a good depiction of where a patient is at when they're in an emergent suicide crisis state. So all of the upstream opportunities that we have in place to assist with their mental health needs have not captured that veteran. So now they're downstream and they're at the end of their rope, right? End of the stream, and they're in crisis. We need to intervene immediately. It's important to note for compact care in general that it's not for routine mental health care or screenings. And that would be where we would capture that veteran upstream in this picture. It's beyond that routine mental health care and screenings. Next slide, please. So eligible veterans that are in an emergent suicide crisis can go to any VA or non-VA facility who are capable of furnishing 24/7 medical and mental health supervision for treatment of that emergent suicide crisis care. There's no out-of-pocket costs for the veterans if all administrative and clinical eligibility requirements are satisfied under Compact Act. For substance abuse rehabilitation facilities or clinic or centers, that is not to be used for that initial treatment of acute suicide crisis or that emergent suicide crisis care. Next slide, please. So once VA does receive medical records for that self-presenting emergency care, VA is authorized to deliver or make determinations and pay for that emergent suicide crisis care treatment. We can also pay for that emergent suicide transportation. So that initial ambulance transport from wherever that crisis care started. So the ambulance transport, let's say home to a ER. And then we can also transport them from that ER, for example, to a acute inpatient mental health facility, for example. Transportation beyond that is not covered under the Compact Act itself. However, if the individual is eligible for the beneficiary travel benefit, then transportation could be applied in those situations. Suicide crisis care authorizations under Compact does also pay for related prescriptions. The authorization under Compact can pay for up to 30 days of inpatient or crisis residential care or 90 days of outpatient care. It's important to really stress that once VA receives those medical records, only then can we make payment determinations. We cannot approve that care for payment until we have those medical records and we can adjudicate those administrative and clinical decisions. Next slide, please. So who is eligible under the Compact Act? So prior service members who were discharged dishonorably or under a general court-martial are not eligible for the Compact benefit. Veterans who did serve prior to September 7th of 1980 are eligible if they meet discharge conditions. And then veterans who were enlisted or commissioned after that date or in active duty after October 16th of 1981 must have served 24 months or active service and met discharge conditions otherwise. If they were discharged for a disability that was caused or made worse by their active duty service, or they were discharged under a hardship or often referred to as an early out, they would be eligible. Go to that next slide, please. So continued eligibility criteria includes veterans who were discharged other than other honorable conditions, and they are eligible if they served 100 cumulative days in a combat zone or in support of a contingency operation directly or as an unmanned aerial vehicle pilot, or if they were victims of sexual assault, battery, or harassment while serving in the armed forces. One misconception we have around a Compact Act, and it's important to note that veterans do not have to be enrolled in the VA system to be eligible for the Compact Act benefit. Next slide, please. To determine the clinical eligibility, this can be done only by a trained crisis responder or healthcare provider that can determine that emergent suicide crisis. And again, important to note, without those medical records, VA cannot make this clinical determination, and the veteran's care cannot be approved until those medical records are received. And then VA administrative and clinical determination then is made. And even when these decisions are made, even when a veteran is otherwise eligible for healthcare benefit, the Compact Act will add additional options to their care, even if they're otherwise eligible for VA healthcare. It is really important that VA is notified as soon as a patient is identified as a former service member or a veteran. Immediate VA notification allows that timely coordination of care, sharing of available medical and mental health information that are vital to the veteran care. It also expedites that VA payment decisions. Next slide, please. When you do identify a former service member or veteran, providers should be notifying VA as soon as possible using our online emergency care reporting portal, and I have that linked here on the slide, or we have a phone number that you can contact us at. This allows VA to begin that determination of the administrative and clinical eligibility of that service member. Also allows the initiation of that care coordination, allowing VA to provide concurrent and future care eligibilities and care options to our community partners to minimize that risk of any interruptions in care needs. Next slide, please. So there are a few different pathways that veterans can receive access to care. Obviously, we have our Veterans Crisis Line, dialing 988 and then pressing 1. They can call 911 or get to that nearest emergency department as soon as possible during a medical or mental health emergency. Veterans, when they do arrive, they should let the staff know that they did serve in the military so that facility can contact us as soon as possible. And just a reminder, emergencies are never planned. Veterans and their family members should identify where that closest emergency department is before they actually need the help. And we have a link here that assists in finding emergency facilities closest to your location and the associated VA. Next slide, please. Here are some resources that I hope are of benefit to you or any veterans that you serve, or if you are a veteran yourself, it is of benefit. Our Veterans Crisis Line information. If veterans have hearing loss, we have an additional phone number that they can use to access. Veterans can also text or visit our crisis line electronically through any mobile device or computer. We have our emergency medical care information for our community partners on our public-facing webpage. I have that linked here as well. as well as the emergency care information for veterans who are getting care at non-VA facilities. Next slide, please. Here is my contact information. I see someone had asked earlier for that. Here is my VA email. For any information you have for me, please reach out anytime. And I hope this was a benefit, and thank you all for your time and for helping us serve our veterans.
Stacy, you're on mute.
Thank you so much. I should say that I really appreciate the information, Michelle. Before I joined SAMHSA many years ago, I actually worked as a social worker doing emergency mental health assessments within a VA's emergency room, and had a lot of contact with veterans who'd experienced mental health emergencies when they were away from a VA. So it's really wonderful to see that VA has created this program that provides a mechanism for veterans to have payment rendered directly for that care when they do experience emergency suicidal crises and they are not in proximity to a VA. I did also want to add that CCBHCs and the Compact Act in some ways are two separate topics, but we did want to cover them both here today because they are important ways that veterans can receive care within communities. So did just want to clarify that piece because we've seen some questions about that. CCBHCs are administered through the Department of Health and Human Services, including SAMHSA, and the Compact Act is administered by VA. I did want to also bring to the stage our final speaker, Sarah Strang. Sarah Strang works in Harris County, Texas, for the Harris Center, which is a CCBHC that is funded through that state demonstration project. I know that Drs. Abdullah and Ibrahim talked about those different funding streams that are available for CCBHCs to be created. So that is how Sarah's CCBHC is funded. They also have a really dynamic collaboration with their local VA, the Michael E. DeBakey VA there in Houston. So Ms. Strang is going to come to the virtual stage and tell us about that collaboration and how they serve veterans through the Harris Center for Mental Health and IDD. Ms. Strang, the floor is yours.
Thank you so much. So I have been with the Harris Center for over 16 years, but with the Mobile Crisis Outreach team for the last 10. And when I joined the team, this was kind of before the MOU. We had veterans that were coming to our organization, and we had a eligibility center where they kind of came and they drew a number, and then their number was called. They went to the desk and presented their paperwork for eligibility. And oftentimes would mention that they were a veteran, and without proper training, sometimes were turned back over to the VA. And when I heard about some of these things, knowing that I work for the Mobile Crisis Outreach team, we serve all of Harris County, which is a little less than 5 million people in the Houston area. And I thought there's got to be a way to change this. And then, so knowing that the Mobile Crisis team can serve anybody, doesn't matter if they have insurance, they're undocumented, they're veterans, they're active duty service members. And when the eligibility center would get confused about whether or not that person that is stating that they're a veteran and was not eligible for services at the VA, we really worked to serve them. And then in 2018, with the Mayor's Challenge and our just different community groups that serve veterans coming together for that Mayor's Challenge, one of the compliance officers with our agency is very passionate about veteran services like me. We worked together with the VA, and she said, we're going to have this MOU or care coordination agreement within 30 days of starting it. And
the VA with the federal government kind of thought we're that's crazy. There's no way that that's going to happen. And believe it or not, it happened. It took a little over 30 days, but under 60 days to get that accomplished. And now with this MOU that we've had since August of 2018, we the VA, if they have anybody that is not eligible for services, whether it's in their ER or the suicide prevention counselors are screening them over the phone, and they are not eligible for one reason or another to go to the VA, then that individual with the VA will call our crisis line that is managed by staff that are here at our agency. And that referral becomes what we consider with our mobile crisis team an urgent referral. So we have less than 8 hours to respond to that referral. Usually as soon as we get it, we're responding with a crisis team. So I manage a team of about 50, and I have 2 to 3 crisis teams per shift, 24 hours a day, 365 days a year. And so we are then responding to that referral. We will go to the home and meet with that individual if they are needing that. Now, sometimes they spent, maybe half a day in the ER and they would really like us to come out tomorrow. We're going to screen, make sure that they're safe and that that's okay. And if that's what they're asking for, then we will do that. But this has just been invaluable. It's for anybody that, like I said, is not able to be served at the VA, but also for veterans, maybe who don't have the best opinion of the VA. We will also serve them and then kind of encourage them to go back to the VA if that's something that they're interested in doing, because they may have better benefits that they're eligible for at the VA, or we'll help them with getting connected to different organizations that can help them with getting re-rated to maybe be able to be eligible at the VA. And then also that backward and forward, I know that some questions have been asked about this. If we are on the scene, so we get a call from maybe 911 or a crisis line, and that individual is saying that they need help, and we find out that they had served in the military, we are always going to call the VA. They give us 2 numbers that we can call that are 24/7, and we can say, hey, this is Sarah Strang. I'm with the mobile crisis team with the Harris Center. I have this individual. This is their name. This is their social. And I need to see if they can go to the VA hospital, or should I take them to our psych hospital within our agency instead. So if they look like they're eligible, the VA will say, yep, come on in, and we can even call the ER for you and let you know that the team is coming and bringing a veteran. If they're not eligible, they'll let us know, and then that way we can take them to another psych hospital where they will not get a bill for going to the VA and not being eligible. And that's huge for us. Somebody who's suicidal with a plan, we don't want to take them to a hospital where then they're going to get billed for that. If we take them to our hospital and they can't pay, we keep sending the bill for about 6 months, and then it's just stops. So that has been huge, and we have really worked together in our community. Next slide. And so how did we do this? Well, we started with the largest system. Like I said, the Harris Center serves a little less than 5 million people. We decided we're going to take this on. We met with the different organizations, kind of discussed the process for handoffs, what that would look like. And we've had to refine that throughout the years and really figure out what the best plan is. Also, making sure that the coordination is not just with me and with maybe my colleague at the VA, Elizabeth, like that we know the systems inside and out, and we have a plan set up so that if I leave, then the plan will continue. And that has been really huge for us. Also, just having a legal department to review it. We formalized the MOU, leadership signed off on it, and then we worked to help duplicate that across the healthcare systems. So next slide, please. And so you will see, this is kind of a copy of the first page of our MOU. I know that they will, the organizers of this webinar will share this. We are happy to share the template. We know that this one has been approved by the VAs, and so it should really help you. You can tweak it how you want. But as you can see, the Harris Center, and then 6 other local mental health authorities adopted. Basically, they took our care coordination agreement and they adopted it for their local mental health authority. And so now we have 29 counties in this one catchment area for the Houston VA that all have MOUs. And so that is huge for the VA too, because if somebody isn't in our catchment area, but they're in, let's say, the Spindletop area or the Burke area, then they have a contact there with their crisis line. And then they will be able to get that veteran the services they need in their county. Next slide. And so the worry always kind of is how inundated are you going to be with veterans? And I still think we're missing some veterans that maybe are not identifying themselves as veterans, and I'll talk about that soon too. But you can see that in the fiscal year 2022, we had 26 referrals. We had a little more in fiscal year 23, about 34, and then fiscal year 24 so far we've had 26. So we'll calculate that again in September. And those are calculated by our crisis line. As those referrals come in, they ask if that individual is a veteran. They also ask, we have a referral source. So it'll say VA hospital. It may also say Harris County Veteran Service Department. And all of those referrals that come in from the VA or any of our veteran organizations that we have MOUs with, then they are considered urgent and we are responding basically within that hour to that call. But these are the individuals also that you would serve anyways. And that's why, we really try and talk about that. These individuals are the ones that, for the most part, are not eligible for service to the VA. So our community, our local mental health authority is going to serve them anyways. The VA is just helping get them to us. And also, a lot of times we're going to be the first eyes on veterans and service members who are leaving the military because they're not necessarily registered right away with the VA. They have to go and do that. So we know that there's a very high risk of suicide when somebody is leaving the military. And so I really stress with my staff about the importance of being able to identify a service member. Next slide. So this is a kind of what I call collaboration in action. When we have this MOU, these are the things that can happen. So a disabled veteran called the crisis line, anxiety, depression, fear of being homeless the next day. Our clinician went out to see that individual. They were able to get them into the hospital. And they also then when that individual was ready for discharge, they didn't have a plan necessarily. And they were able to contact us. The hospital also contacted us. And we got involved with Harris County Veteran Service Department. And together, we were able to get that individual a hotel room. And then the Harris County Veteran Service Department worked to get him into the Warrior Refuge program. And that's where he was connected with housing, counseling, psychiatric services, training, and other resources. And it just took a team effort because we needed all the information from the VA, as well as the help from the Harris County Veteran Service Department, who are also veterans working together with us. Next slide. This is another one that I'm always really proud of because this one came from our 911 Crisis Call Diversion Center, which is embedded. We have crisis counselors embedded in the City of Houston's 911 dispatch center. They got a call that there was a veteran feeling hopeless and helpless. So September, they went out there, they kind of did a crisis assessment, figured out what he needed. And I believe with this individual, we were even able to get him in to see our psychiatrist because she had an opening that day. We had him see the nurse. We were able to start him on medication and connect. We were able to call the VA and we kind of knew, what services he was able to get there. And we also connected him with Harris County Veteran Service Department. They were able to help him, I think, with getting back into college and also some help with his car that wasn't starting. And then we were also able to link him to one of our clinics and then gave him the option if he was eligible in the future to go back to the VA as well. Next slide. So this is kind of what we took the mayor's challenge that we formed, and we turned it into, because that was really for the city of Houston, and we broadened that to include all of Harris County. And so we have named that Spark H2 Houston and Harris County. And SPARK stands for Suicide Prevention and Resource Coordination. And these are a few of the different members of that committee that meets. We meet like once a month. Everybody and anybody is always welcome. And so this is kind of an ever-changing group. And like I talked about earlier, where we want to make sure that it's not just one person. So anybody is from any of these organizations, or anybody that touches a veteran that wants to learn more about like what we're doing in our community is welcome to this group. We've even had different cities in Texas and different communities in Texas outside of our area come and listen to the meeting so that they can learn how to kind of put something together in their area. And like from Austin, we've really kind of developed these different collaborations, and some of them are doing really great things, and we're learning from each other. And so it's just this great kind of web of connections that we have. Next slide. And like I talked about with the Harris County Veteran Service Department, this is their QR code. I wanted to put up there in case you guys were interested in kind of what they do. I know that they have now a Sergeant S. Fox grant where they're able to serve those that are suicidal and provide additional resources for them. And one of the cool things is, and I almost even pulled the two in today, but they actually went out on a crisis call with my MCOT team. But we have two brand new employees of the Harris County Veteran Service Department that are shadowing us, my staff today. And we do the same thing, like we may go shadow them as well to learn more about hands-on what these organizations are doing in the community. And so they can share that firsthand knowledge with the veteran, and we can share with a veteran that may not be connected to them what they can do. Next slide. So this is just kind of talking about overall benefits of community collaboration work. Like, why is this so important? We've really developed close working relationships with multiple agencies that assist people we serve. I learn something new every month that I attend these meetings because there are so many great organizations out there that really want to help veterans or just people in general. You know, when we talk about this, we talk about just helping people. If we're helping veterans, we're helping their family, we're helping their children. They may then share that they had help and how to get the help that maybe their neighbors or colleagues may need. All of this is, like I said, we are very proud of it. We didn't get any funding for this. We, put together this group, and we have really kind of had a passion to keep it together and to keep learning from one another. And the nice thing is, like when we've had hurricanes, we've had a lot of weather events this year, but even just through COVID, when things changed and people went virtual and we're working from home, then we still had that connection within each other. Next slide. So some of the things that our mental health authority to identify the veterans and their family members that we're serving is we have added these mandatory questions to our electronic health record, and we use Epic. So the question when they're getting an assessment was, have you ever served in the military, which is a big deal because we want to make sure that we're incorporating everybody, and not everybody considers themselves a veteran, even though they have served in the military. And then if they answer yes to those questions, what branch, and was the discharge honorable or dishonorable, or do they just not really, sometimes they'll say they don't know if they're too psychotic to answer that question, then we may have to skip that. But, we do some training around what, asking this question, because some people are like, oh, that's going to upset a veteran if you're asking that question. But just as we talk about, in our assessment, well, what legal charges have you had? What drugs have you used? What drugs are you currently using? We talk about this in the form that it doesn't matter to us what your discharge is, but it helps us determine where we should take you, where we should help you with getting help, what referrals we should make to help you maybe get that discharge to become honorable potentially. And we present it in that way, and it works well. Next question, next slide, I mean. So this, I like to kind of share like how we've done these success stories. And this is a 49-year-old female veteran who was referred to MCOT by the VA hospital. She was struggling with suicidal thoughts, drug use, needing to get help, and potentially they kind of thought that she should be able to be re-rated to be eligible for the VA services. So our mobile crisis team worked with her for 7 months. We were able to stabilize her, help her see our psychiatrist. Excuse me, she even saw our peer. We linked her to a sober house, to AA. She received medication management through her MCOT psychiatrist. She made progress on case management goals, such as getting her nursing license back, her driver's license. She actually had lost her ID, so we have a homeless ID that we can get her through the City of Houston Police Department, and got her other identification cards back from there. She was linked with the VA hospital, where she is seeing a psychiatrist receiving occupational therapy, because we were able to get her re-rated, and has continued to take her medicine regularly and abstain from drug and alcohol use. Next slide. And so one of the things that I've really tried to work hard on across our agency, and we have several thousand employees within our agency, is encouraging them to have mandatory military competency training across their programs, all of our programs. And that goes from the front desk person who's doing a check-in and asking questions, maybe for financial documents, all the way to the clinicians and the psychiatrists. Having them understand some of the military lingo and jargon, and understand, how to ask someone, like, well, did you serve in the military? What was your MOS? Getting, even if they're not veterans, getting them kind of comfortable with some of the language. Also, the Texas Veterans Commission, they offer some amazing trainings for us, and so I've provided that website. We have in Houston an annual Veteran Mental Health Summit, which actually is what even sparked my interest in this many, many years ago. And so that's another way for us to send our employees to get additional training and connect with the community. And then my first Veteran Mental Health Summit, this TED Talk was played. And while the number, I do not believe it's 22 anymore, I think it's about 18 suicides, which is still too many. I think I've watched this probably 50, 60 times. I have all of my staff watch it once a year as a reminder of how veterans feel, displaced. They feel like nobody notices them, and they have a hard time fitting in when they are discharged from the military. So it's very powerful. Next slide. Also, anybody can get free gun locks from the VA. I actually just ordered another 500. They come in a box of 100, and the boxes, then there's 4 boxes like this that have 25 gun locks in them. We try and put them out at all of our clinics. When we're going out in the community, sharing about our programs, we give them out. We're going today to the Harris County Sheriff's Office and talking about the mobile crisis teams and our agency. And we give these gun locks out to the police officers. We encourage them to have them in their car. They have the veteran crisis information on them. We actually even use them. Let's say somebody's living by themselves and they're either suicidal, but they're not willing to give us their gun. What we've done is we have a yellow cup that says the Harris Center, and it has our crisis line number on it. And we'll tell them, why don't you put the key, lock your gun up, put the key in the cup, fill it with water, and then put it in the back of your freezer. So that it's just putting time and distance between them being able to use that gun and maybe seeing the crisis line number and calling the crisis line number instead. So anybody can get these, and that is how you do it. And they usually ship by UPS within a week or so. Next slide. And this is just, a helpful slide that I've gotten from the VA, how to find your nearest locations. The MOU, or if you guys need a contact for our VA, I know that Elizabeth Kleeman and I have really wanted to make sure that we can help all the different LMHAs across Texas get connected to their local VA, as well as across the nation. It's our goal to do that. So I can drop her email in the chat as well.
Strang, I really appreciate the information that you've presented. A lot to unpack there. It's really great that you all have developed this true partnership with other kind of veteran serving programs in your area, as well as your local VA, that MOU that you all have had for many years together. It sounds like you have a really great partnership with your county veteran service department that is really mutually beneficial, as well as the local police in your important on the ground crisis intervention work. I'll also mention that you talked about how you all evaluate veteran status, not necessarily using that word veteran that doesn't always resonate with everyone. But asking, have you ever served in the military? That's a definite approach that we recommend from the SMVF TA Center as well. Great information about gun locks. That lethal means safety piece is so important when we are talking about suicide risk. Also, shout out to the Mayors and Governors Challenge. There might be some folks on the call who participate in their jurisdictions. Also, just want to give a shout out to VA's Community Engagement and Partnerships Coordinator program. Most likely, if you are involved with the local coalition, you have had contact with the VA CEPC, the acronym that they use there. In terms of community-based interventions for suicide prevention. So thank you for bringing up a lot about what's happening on the ground in Harris County. I did want to invite our other presenters, if you'd like to come on camera, to give some time to address some of the questions that we've received. Many of our presenters did an awesome job of answering some of those questions right there in the Q&A pod. So if those questions have been answered, you all have access to them. But I did want to kind of bring some things to the forefront and have a verbal conversation about a few things so that we can kind of address it a little bit more broadly. First, I noticed that we had a few questions in the chat that seemed to be more closely related to VA's community care network, which is different from the Compact Act. So I invite Ms. Suri, could you tell us how those two things are different, and how, if folks need more information about community care network, how they can get that information?
Yeah, Community Care Network is a vehicle that VA uses based on the Mission Act legislation, which allows us to furnish and pay for care outside of VA. Compact Act is unique in that it does not require community providers to be in VA's network like all other care has to under that Mission Act regulation, meaning that a provider out of network can also be provide this care to our veterans, and VA can refer to out of network providers as well for compact care if they're willing and able to accept that referral and authorization. So if you have questions about joining our network, please send me an email and I will get you in contact with the individuals who can assist in making sure that happens.
Thank you so much. Really appreciate that piece of information. That's definitely an important part of the community availability for veterans. Unfortunately, we just didn't have the bandwidth to address that component as well on this particular webinar. So thank you for being available for additional information. Again, did want to highlight a few things. There were some questions in the chat regarding CCBHCs and if they have to serve anyone. So I'll make this a two-part question. There was also a question about veterans who are eligible for VA care, but still wanting to opt to go to a CCBHC for their care. So Dr. DeSala, I saw that you came on camera as well as Dr. Ibrahim. So I think that question would be a question for one of you. Do CCBHCs have to serve anyone? And what if the veteran is eligible for VA care, but they want to opt to be seen at their CCBHC instead?
Yes, so
Go ahead, Dr.
no,
Ibrahim.
go ahead, Leila.
Well, the sense of the CCBHCs are available to anyone that if an individual walking into that building, they will not turn anyone away, regardless of their insurance, regardless of their availability to pay. They're available 24 hours, 7 days a week. But you also have to think of a CCBHC in a sense. The CCBHCs must meet a stringent criteria when it's coming to the timeliness of access of services, care coordination, quality reporting, staffing, scope of services, and in return, they receive a Medicare payment based on that prospective PPS system. So I just wanted to make sure that I, conveyed that information. But Dr. Ibrahim, you can provide additional information as well.
Yeah, so of course, access to services is freedom of choice. So for anyone that is interested in receiving services from a non-VA veteran who wants to get services from a non-VA location, do have the right to go to the CCBHC and be able to get that services. CCBHCs are required to provide care to anyone who walks into the door, regardless of their ability to pay, as my colleague Dr. Sola just mentioned. So yes, they have the right if they don't want to get care from the VA administration, but do want to get care at the CCBHC to be able to get that access.
Thank you. Ms. String, I'd also like to invite you to have the opportunity to respond to that if you'd like, because we did have some questions in the chat about whether your care coordination agreement only covers like the MCOT part and what happens after those initial kind of crisis episodes within your particular CCBHC.
Yeah, absolutely. No, when we do these care coordination agreements, and I think, done like 15 of them in the last couple of years, we always do it for the whole agency. So it covers any programs that the veteran is going to touch and or family member, right? Or veteran or even active duty. It doesn't matter who that individual is at any program that they come into, whether that's our neuropsychiatric center, whether it's a crisis residential center, whether it's one of our clinics, they come in as a walk-in. If they mention that they're a veteran, and we want to confirm that, or we want to help them with whatever it is, anybody in our agency can do that.
Thank you. Appreciate that. There were also a few comments in the chat regarding VSOs. And for those who may have seen that acronym and not been familiar with it, that stands for Veterans Service Officer. And there were really questions about how CCBHCs might be working with VSOs. And Ms. String, this question is for you. I noticed that in your scenario that you had about the female veteran, there was some desire to have the discharge status upgraded. So wondering if you could speak a little bit to the VSO connection with your particular CCBHC, and if veterans do have questions about their discharge status being upgraded, how you all support around that topic.
Yeah, we're really lucky to work with, like I said, our Harris County Veteran Service Department. So anytime that there is a need for any kind of referral that we don't know, because we're not the experts in veterans, right? We're the experts kind of in crisis and getting them stabilized. But we will, we have a great referral process. If you go to the, maybe somebody can post the link of that, of the Harris County Veteran Service webpage. But there's a referral form to fill out online. So we get our consent from the veteran or person who served in the military to see if they're okay with us making that referral. And then we'll follow up on that referral. So while we're working with them and stabilizing them out of that crisis, we're seeing them face-to-face 1 to 2 times a week or more. If our doctor says daily, then we're going to be seeing them daily. So we're working with them on that linkage piece and figuring out what we need to do in order to help with that re-rating. We're not necessarily doing it, but we're referring them to the organizations that we've connected with to work on that. And so that was the, a 7-month case. Usually we work, usually we're opening and closing cases within 60 and 90 days. So we're able to link them that quickly. But this one needed a lot of different things. And in particular, even that homeless state license, which allowed her then to be able to get her regular driver's license and birth certificate.
That is helpful. It sounds like the veterans who come to your program have definitely benefited from you all having that direct connection with that that local VSO
Yeah,
entity.
and it takes the pressure off too of us having to know everything, right? They are the experts in all of that. Or if they need, have some questions about, do they need to hire a lawyer to get, a higher service connection, whatever, all of that is handled by Harris County Vets.
Yeah, I think that answers another question that's come up for some folks in the chat who are working with CCBHCs. They were wondering if they have to have someone in-house with that direct knowledge. But I think you answered that well, that you have that formal agreement with an entity that does have that knowledge and can provide that type of support. So
and if anybody would want that connection, Dave Lewis, he's the director. I'm sure, we're all about helping others and helping them get those connections. So somebody can just email me directly and I'll be happy to connect you with Mr. Dave Lewis.
Thank you for that offer of connection. There was a question from some folks regarding electronic health records interoperability. And I did want to give Dr. Abraham and Dr. DeSala an opportunity to answer that question about expectations around health records systems, electronic health records for CCBHCs, if you wanted to address that.
Hi, this is Dr. DeSola. I just wanted to backtrack if you don't mind concerning.
Sure.
I know that the certified behavioral health clinics, community behavioral health clinics, they have DCOs, and the DCOs is designating collaborating organizations, and the role is identified in statute. And CCBHCs can elect to either provide directly the services that are required in the CCBHC model, or they can choose to provide services or part of those services to a DCO. So, and the DCOs are not really under the direct supervision of the CCBHC, but they're engaged in a formal relationship, which is a signed agreement with the CCBHC to deliver one or more of those elements of the required services. So I just thought it was important to highlight that. And it's also really important from the perspective of the person that's receiving those services or their family members. Services received through that DCO should be part of that coordinated package, a seamless package with other CCBH services, and not simply accessing services just through another provider organization. So you have to think of it as one whole package of coordinated services, and it's not just contracting out services. So it's about contracting in services into this comprehensive array. So I just wanted to share that as well.
No, that's really helpful. So thank you for stepping back to that question. The DCO acronym, I was trying to think of it when I was discussing those types of agreements. But it definitely elevates that type of agreement to another level, making sure that all of that information and knowledge is still in-house with the CCBHC as kind of that coordinating entity, so that it is known what is going on with that person kind of through every sphere of how should I say, services that they're receiving related to their mental health. So thanks for clarifying that piece.
Sure, and I just wanted to, also, and now that I think about it, I'm sorry, but, CCBHCs are really responsible for ensuring that individuals that's receiving those services get all 9 services in a way that meets the requirements of the CCBHC criteria. So it's just not okay for CCBHC to say, our DC services fell through, or we can't provide these services. The CCBHC is still on the hook for providing those services, and the CCBHC should always be watching for these agreements very closely to make sure that they're meeting the criteria, the certification, because your DCO, it's so important for the CCBHC to make sure that there's a backup plan, that there's a compliance, and also just to make sure that you're representing those in the community that walk into that CCBHC, that you're making sure that it's a seamless package for those individuals that's receiving services, regardless of their DCO relationship.
Thank you for that.
And just to add to that, I mean, the CCBHC care coordination, the criteria on the care coordination requires that the CCBHCs establish or maintain a health information technology system that should include at the minimum the electronic health records. So that is part of their requirement to be a CCBHC.
Thank you for that. I did want to circle back to Ms. Sori. I know that we had some questions in the chat about kind of the method of submitting requests for reimbursement under the Compact Act. Community-based organizations that wanted to submit that reimbursement request. Do you have any indications of kind of best practices or tips and tricks, or any kind of common pitfalls that some organizations might have expressed that they've experienced when going through that process that you could address?
Yeah, tips and tricks is for sure going to be notifying VA as soon as you identify a former service member, so that we can determine that administrative and clinical eligibility as soon as possible, so that we can guide you in the number one, if VA can even pay for that former service member under Compact Act, and to help guide you through that billing process. If you are not in our CCN network already, you will need to register with sam.gov, so that if VA can pay, that we have a way to pay you, right? And so that registration with SAM, it's sam.gov. Registration is important so that we can get that vendorization complete, so that payment can go through. So those are the two tips that I can provide that do have to be in place for that smooth payment process to occur.
That is very helpful. Thank you. Did have a kind of a closeout question that I wanted to elevate here. If we have a general CCBHC question, is there a preferred point of contact? I believe that we had an email address on one of the slides earlier. Dwayne, if you could help me out and put that in the chat for us as well, that email address for the general CCBHC inbox. We can provide that for you all. I did have a couple of questions about if you all will receive the slides and the recording and information that's been put in the chat. And we certainly will compile all of those pieces and send them out to everyone who's registered. So even if you've only saw part of it or had to drop off early, you'll definitely still get that information in your email inbox. All right, I'm actually not seeing any other questions come through in the chat, but I did want to give our presenters, if you wanted to just provide some closeout, either recommendations or thoughts on this topic. Ms. Sori, I asked you to do that a bit already, but for I'll give Ms. Strang an opportunity. If there's anything that you wanted to say to either your fellow folks who are operating CCBHCs or folks who might be on the other end, on the VA side or the community side, any kind of last words that you would offer to them in terms of this work?
Yeah, I think that one of the things I just really emphasize is don't give up. I know sometimes it's frustrating. I'm trying to get connected or trying to find the right person, but just keep trying. Again, am happy to offer any assistance that I can, as I know Elizabeth Kleeman with the VA or Dave Lewis with the Harris County Veteran Service Department. We want to help people because we do not want any veterans or their family members to slip, between the cracks. Our goal in Harris County is there's no wrong door for a veteran or their family members to enter, and that we'll find them the right door that will be the most helpful once they do enter. So I just really encourage that. I can't tell you how much it is a passion of ours to help make this, something countrywide that is easy for anybody that needs help to get access.
Thank you for that advice. I have mentioned that prior to my SAMHSA life, I did work in VA, and technically I worked at 3 different VAs. And there's a saying that if you've seen one VA, you've seen one VA. So things do differ, across the nation in terms of those connections and the path for those connections. So I think that yeah, that advice on kind of not giving up and not expecting your experience to be quite the same with someone else's, but really knowing that it's a valuable resource that we have is important. So thank you for that. Dr. Ibrahim and or Dr. DeSala, any last words that you wanted to share with attendees for this call?
Yeah, I think what I can add is that, of course, it is already included in the CCBHC criteria that all CCBHCs serving veterans must train or ensure that their staff are trained to be able to provide services to veterans. And as part of the CCBHC demonstration program for states that are selected or were selected to be part of the CCBHC demonstration, as Dr. DeSala had earlier on outlined, each of the state can actually add their own criteria to the already established CCBHC criteria required for services. So, and for some of the states, they are making it mandatory that for any CCBHC clinic to be part of the demonstration, the state demonstration, they must ensure that evidence-based training on how to provide services to CCBHC clients who are veterans should be core part of their staff development. So I just want to add that for folks.
I agree with Dr. Ibrahim. Totally agree. He just took my key points. But the bottom line at the end of the day is to make sure you check out the links that was provided concerning the CCBHCs, because quite often the community does not even know that the CCBHCs exist, and they operate 24 hours, 7 days a week, regardless of that person's ability to pay for it, regardless if they have insurance. So I encourage and really would love for everyone to share this information and network and encourage all those that are involved with veterans families and active duty personnel to really just check out the links and share the information, because it's so important. But Dr. Ibrahim took my points. So, but I thank everyone for listening to our presentation here from SAMHSA. Thank you so much.
Yeah, hugely important points. I'll echo Dr. Ibrahim's piece about the importance of military cultural competency training, as well as those evidence-based treatments that have been really tested on individuals who have served, as well as Dr. DeSola's words about spreading the word about CCBHCs. What's difficult is if you, I was about to say look in the phone book, that's a dated reference. If you look on Google and you just type in the word CCBHC, it might not necessarily, pop up as the Harris Center, like Ms. Strang's CCBHC, or the many others that go by their own unique names, but receive that CCBHC funding and are required to operate in the ways that you all have outlined in your presentation. So definitely spreading the word about the availability of them and following those links to identify CCBHCs in your area. As you see, this is our information about SAMHSA. You can always connect to us and our other programs and resources through samhsa.gov. And one more slide, please. This is information, again, this webinar has been sponsored by SAMHSA's Service Members, Veterans, and Their Families Technical Assistance Center. If you need more information about the SMVF TA Center, feel free to reach out to their contact information here. Thank you all again for joining this webinar to discuss clinical partnerships to support service members, veterans, and their families. We hope that you all will join us for another technical assistance event in the future. Thanks and have a great day. Thanks so much again to our presenters as well. Have a good afternoon, everyone.